Good day, everyone. We are thrilled you've joined us for our very first Learning Live session, implementing the 2025 International Wound Infection Institute guidelines, making therapeutic wound cleansing standard at the bedside, sponsored by Ergo Medical. My name is Miranda Henry, and I'll be your host for today's live broadcast. Whether you're joining us on YouTube, Facebook, or LinkedIn, welcome. This is a brand new format we're launching today, and we're so excited to connect you in real time across these multiple social media platforms. I have a few quick notes as we get started here. This session is being broadcast live and will be also made available on demand after today's program. We want this to be interactive, so please don't be shy. Drop those questions in the chat throughout the presentation. We'll be monitoring all platforms and we'll address as many questions as possible during our Q&A segment at the end. And don't forget to like, share, and engage with today's content. Help us spread this evidence-based wound care education to your colleagues and throughout your networks. And if you happen to experience any technical difficulties during the broadcast, try refreshing your browser or switching to a different social media platform where we're streaming. Now, before we begin, please note the following important disclaimers. This webinar is presented for informational purposes only. The content is intended for healthcare professionals and is not a substitute for independent clinical judgment or institution protocols. Participants should consult applicable clinical guidelines and facility policies when interpreting or applying information from this program. The views expressed are those of the presenter and do not necessarily reflect those of the organizers or any sponsors of the presentation. So for a little background on today's webinar, the 2025 International Wound Infection Institute guidelines represent a major shift in wound care, defining therapeutic skin and wound cleansing as the foundation of wound bed preparation. However, implementation remains very challenging, with only one wound ostomy continence nurse for every 250 patient beds, and 75% of those nurses reporting their orders aren't being followed. We've got a lot of work to do. So today we'll be exploring the critical role of pH in Therapeutic Index and sharing approaches to help you improve compliance, streamline protocols, and empower your full wound care team. And with that, it is now my great pleasure to introduce you to today's speaker, Ms. Kara Couch. Kara serves as the Director of Wound Care Services at the George Washington University Hospital in Washington, D.C., is an Associate Research Professor of Surgery at the George Washington University School of Medicine and Health Sciences. Kara's a distinguished leader in wound care. She is the current Vice Chair of the Alliance of Wound Care Stakeholders and President of the AAWC. And as a fellow of the AAWC, she serves on multiple editorial boards and is co-chair of the wound care community for the American Association for Nurse Practitioners. Kara brings not only deep clinical expertise, but also a practical, boots-on-the-ground perspective on what it takes to implement change at the bedside. Kara, I'm so excited that you're here today for our first Learning Live. Over to you.
Thank you, Miranda, and thank you so much for Wound Care Today USA for inviting me. It is my great privilege and pleasure to be here. Goodness, it's noon. You'd think I'd be able to talk already. Let's get this going. So these are my disclosures. And Miranda just mentioned that we have a big challenge where there is a lot of process variation, which leads to these unpredictable outcomes, where if you look at wound care by the numbers, simply looking at inpatient wound ostomy continence nurses, this was a survey done in Pennsylvania a couple of years ago, where 86% reported that there was an average of 4 or more departments involved in wound treatment and 4 or more prescribers involved in a wound treatment plan. There's many cleansers. Almost half of them have at least 4+ cleansers. And, as we said, we don't believe our wound care orders are being followed. It's really, really frustrating. One of the biggest takeaways for me is just that there's simply not enough wound care specialists to cover all of the challenges at the bedside. And that leads to what I call reactive care, not proactive care, because you're spending so much time just trying to keep your head above water there that you can't actually, move your programs forward in a direction to try and get more predictable outcomes. Now, this inconsistent care leads to gaps in practice, and we found that when it comes to actually cleansing wounds, that it is the terminology is defined in literature, but it's not well defined in actual practice with how do people cleanse the peri wound? Are they cleansing the wound at every dressing change? What are you using? There's just a lot of this inconsistency. And with that, it leads to a lot of issues and negative outcomes for our patients. So if we can standardize around this with a single solution, this helps us to meet the criteria that was established by the new consensus guidelines that were released this year. So I spent a lot of time in my facility talking about quality measures and quality bundles, and we have CLABSI bundles and CAUTI bundles and SSSI prevention. But we do have skin bundles. However, we don't have necessarily a skin and soft tissue infection prevention bundle. So this is the last big realm that we need to get to standardize practice to prevent infection, because surgical wounds and surgical site infections are a huge drain on not just our healthcare system from an economic standpoint, but from a research standpoint, and most importantly, from how it affects the patients and leads to horrible outcomes, unfortunately, including death in some instances. So all these different areas, the National Pressure Injury Advisory Panel, the consensus guidelines from the JWC, wound repair and regeneration, they've all recognized these gaps in clinical practice. And this is just literature that's come out in the last 6 years. There's lots of other papers, best practice, that have pointed this out. So what are we going to do about this? And this is where the International Wound Infection Institute released this guideline in 2025. And this is my new favorite thing to teach. I just think this document is invaluable and everybody should be grabbing it. So this QR code that's there, and if you miss it from this slide, we're going to put it up again at the back. Wanted you to realize that anytime you see that green starburst, that means that's that symbol that's there. It's pulled that information directly from this guideline paper, which is all free from that website that you see in front of you and open access for people to download. So number one, what is therapeutic wound cleansing? Let's define it. This is the active removal of surface contaminants, loose debris, non-attached, non-viable tissue, microorganisms, or the remnants of previous dressings, the foreign bodies, the wound debris that gets left in these wound beds in the peri-wound. So the number one recommendation is to therapeutically cleanse all wounds when the dressing is changed or removed. And if I can call your attention to the lower right of the screen there, with the little starburst sign, you see it says page 5 to 6. So that's going to follow through this talk, that it gives you the actual pages, because it's a very comprehensive document to go through. So if you really want to get into it from referencing this talk, that's where the information is going to be. Now, is there non-therapeutic cleansing? And emergent evidence says yes. I gave this slide, I was giving a talk to my emergency department providers, the residents, a couple weeks ago, and we really dug into it. And this is, I think, like really some of the key points I want to share with you today. So this is not cleansing, taking those little squirt, capsules and ampules of saline, doing what we call anointing the wounds. If you ask a patient, how do they cleanse the wound? They're going to tell you that they take a little saline syringe and they go drip, drip, drip. And that little drip, drip is anointing or spritzing. We've gotten away from spraying wounds with spray bottles. Back in the day when I started doing this, that's what we used a lot, but we realized we're just aerosolizing bacteria by doing that. So Terry Swanson, who is the chair of the IWII, she coins it, stop anointing these wounds. And Dot Weir, who we all know and is also serves on the board of the IWII, says we really need to get in there and clean it like you mean it. So we need to scrub a dub dub and get rough on slough and really get in there. I don't know if I've given you enough little acronyms or catchphrases there, but really, this is how we should be practicing. So therapeutic cleansing is visible. This is a wound where I use this example for my ED providers and also my orthopedics team. I talked to them a couple weeks ago, where if you saw this wound and you looked at it as is, that looks pretty disgusting. You can see that the dressings behind it have lots of green exudate and, just really looks, like it could be a big problem. Like this wound is infected. Oh my gosh, we need to admit them. We need to put them on antibiotics. But if you actually clean this wound, you can see that is beautiful granulation tissue. It's nice and beefy and healthy, and it does not appear to be infected. So what you were seeing before you therapeutically cleanse the wound is just debris and junk that needs to come off. So a key practical point is never pay attention to only what the dressing looks like. You must look at what the wound looks like after you've cleansed it, because that is what's going to guide your therapy from there. This is a case example from my own practice of before and after therapeutic cleansing. And that is a lateral leg wound, as you can see. And that is right after the dressing has come off and the patient has just a lot of debris and non-viable tissue, loose tissue there. And then we performed therapeutic cleansing on the right. Now, yes, of course, there's still slough on that wound bed. There's still some macerated wound tissue, but it looks vastly better for a chronic wound that we're trying to clean rather than, or trying to treat, rather than something that looks like it could be harboring a lot of bacteria. And so you really have to get rid of everything on the surface so that you understand what it is you're dealing with. By not doing these steps, this is how we contribute to the overuse and misprescribing of antibiotics. And really, just by the simple scrubbing of these wounds and getting rid of this unhealthy, non-viable tissue, really helps us to reduce that, which also helps to reduce multi-drug resistant organisms, because we're not constantly chasing things with antibiotics which aren't actually solving the problem. Now, what are the challenges of obtaining a clean wound? So, I hear this all the time. I'm not a wound care nurse. Well, yeah, that's true. There are not enough of us. We don't have the tools. If I take a lot of time to do that, I'm going to get into trouble. I'm going to get delayed. My coworkers are going to be upset. I don't want to cause pain and bleeding. Those of us that care for patients, we didn't start doing our practice or get into this to hurt patients. We're here to help them. And I think a lot of it really is because wound care is not taught in medical schools, it's not taught in nursing schools, that people just don't know what to do. And so then they don't do anything. I do think it's only maybe a wound care nurse would say, I need an adequate way to avoid cytotoxicity. But, some providers would want to know about that. So, and wounds are challenging, finally. Like, we know that it's really, really tricky, and people don't understand what it is they're looking at, and they don't know what bad things are and what good things are. So, if we can get to a common baseline of what a clean wound looks like, that helps us to ensure that we're doing the right thing for the patient and that they're getting the referrals and the consults they need to the specialist if they're having challenges. Terry says every dressing change is an opportunity to change the trajectory of the healing of a wound, and I wholeheartedly agree and support that. These dressings are dirty. They've got all of the debris and the gross stuff in there, so we really can impact each wound every time we touch it. Now, what is optimal wound care looking like? Why in the center, with the patient, we're keeping the center of everything that we do, but, we're trying to make sure that we're doing the right dressings, appropriate cleansing, proper debridement, because what we're doing is trying to rebalance the wound care environment. And with that, we're working on our infection prevention and management. We're stimulating the wound bed and we're caring for the individual. So this is why wound cleansing is at the center of optimal wound care. In this document, we are going to talk about solutions. What is the evidence and what are the recommendations? Again, this is on page 19, like I said, in the lower corner there, by the global experts who put this document together. Now, what are the considerations when selecting a cleansing solution? Because as I mentioned before, most people have more than one option. And sadly, most people have more than 4 options. So how do you pick and choose what the appropriate and optimal cleansing solution is? So what we're going to do is we're going to base this on what are we actually doing? What type of wound dressing procedure are we going to be doing? And what type of therapeutic cleansing technique is going to be employed? What does the wound look like? Is there risk or present of infection? Is there an abundance of microorganisms? Do we know what those are if we've actually been able to sample for a culture? What is the cytotoxicity? What is the pH? What is the allergenicity of the solution? What's the goals of care and the individual factors for the patient? Are they immune compromised? We have a patient right now who we're treating with a really, really complex situation with regards to cancer. And I shouldn't say right now, that happens all the time. But we have to take those things into account when we're considering our patients. And then also, what's actually available to us. So there may be an optimal cleansing solution that I want to have, but I may not have the resources or the availability for it. So I'm going to consider all those things when I come up with a solution option. So, as I said, we're going to focus on talking about the pH, the therapeutic index, and the safety profile of these various solutions. Now, the pH basics, we all know a lot about pH. The pH of a wound bed is different from the pH of normal skin. You know, the pH, we want a skin neutral pH because we know that chronic or infected wounds are alkaline. They tend to have a pH towards 7.5 to 10, but healing wounds are acidic. So the pH of normal skin is between 4 and 5.5. So we want to keep getting that pH lower to a skin neutral pH. And every increase of a pH scale is logarithmic. So every time we increase by 1, it's actually increasing by tenfold. So if we are changing and keeping the pH from 5.5 and moving it to 8.5, that's actually 1,000 times worse for that patient. So you're delaying the healing by that, by trying to constantly keep the microenvironment in the scale that doesn't allow for optimal healing. And the effects of lowering this pH to a more acidic environment are we're increasing more oxygen release to the wound bed, we're getting increased collagen formation, macrophages, fibroblasts, the critical cells that we need to stimulate healing. This is getting rid of the deleterious cells like the matrix metalloproteinases, the proteases that are causing these bacterial end products that are toxic, and hoping to reduce biofilm formation and bacterial virulence. Now, what's a therapeutic index? The therapeutic index, this paper came out last year in Advances in Skin and Wound Care, a really great systematic review, highly recommend people get this. But what it's talking about is what the therapeutic index is, the quantitative measurement of the relative safety of the solution with regards to tissue damage in healthy cells. So you have the mean cytotoxic concentration in mammalian cells divided by the mean MBC of the bacterial species. So what you want is a therapeutic index over 1. And it can go higher than 1. And actually, the higher the value, that indicates the greatest safety and potential clinical effectiveness. So when you look at these cleansing solutions, this paper went through all of that. We look at common solutions such as betaine or polyhexamethylene biguanide, PHMB, and they compared that against common bacteria such as MRSA, Pseudomonas, E. coli, and staph. So you can see for E. coli and staph, they had a therapeutic index of PHMB is under 1. So you're not getting a lot of bang for your buck there. Chlorhexidine has cytotoxicity reported. Again, for Pseudomonas and staph, it's under 1 at 0.7 and 0.007 for Staph aureus. Sodium hypochlorite, which is Dakin's or dilute Dakin solution, aka bleach in water, it has no therapeutic index greater than 0.002. So the concentration below this is 0.025% is suggested. And then povidone iodine, again, has a really low concentration. So saline has no measurable therapeutic index. But if I can point your attention back to hypochlorous acid, that is an antimicrobial that's a hypotonic that has a pH between 3.5 and 6.5. And look at the mean therapeutic indices against Pseudomonas, staph, and E. coli. They are all well above 1, and then critically, there's no cytotoxicity reported. Personally, I am not a fan of Pseudomonas. That is my least favorite bacteria, and I really need something that's going to eradicate that because I don't have a lot of good oral antibiotic options for my patients or systemic antibiotic options. Now, as I mentioned, saline does not have a measurable therapeutic index. Dr. Alicia Oropalo, who is a vascular surgeon at Northwell Health in New York, she put this paper out last year in the International Wound Journal, looking at what antiseptic solutions and then the cleanser types and techniques are effective in bacterial burden management. So what they found was that the antiseptic solutions were much more efficacious in reducing the bacteria than the non-antiseptic or surfactant solutions. Surfactant would be soap and water, and non-antiseptic would be saline. So the image that you see there on the bottom, they actually use bacterial fluorescence. And what they found was when you cleanse wounds with saline, what you actually are doing is you're pulling in all of the bacteria from the peri-wound into the wound itself. So they found more wounds in the saline group, 62.5%, had a positive change or an increase in bacteria by unmasking the peri-wound bacteria. So if you've not seen this before, the red bacterial fluorescence lights up. Like you don't want to see the red. That's indicating that you have much more staph or much more of a problem, that after cleansing, you're seeing this in this wound here. So the antiseptic solutions are much more efficacious. So what are we looking for with this? How do we select the best one? What's the tiebreaker? We want to think about what's the therapeutic index, what's the pH, and then what are we going to do? Are we going to use this in debriding our wounds themselves as an amplifier? So hypochlorous acid is actually made by our body. It's our natural response to invading pathogens. And this happens in the oxidative burst pathway, where the pathogens are targeted and engulfed by the white blood cells. Think of it like Pac-Man. They kind of like gobble it up, and then the hypochlorous acid is generated within the white blood cell, which then destroys the pathogen from there. And then all of the end products are released by the body through exocytosis there. Now, when we think about pure hypochlorous acid, we know that it's effective against fungi, spores, viruses, and multi-drug resistant bacteria, and it has a really fast kill rate within 15 seconds. So you're already getting kill against all of like the bad bacteria that we don't like, Bacteroides, Acinetobacter, Candida albicans, and also, again, I mentioned before, but it also has a kill rate against C. difficile. C. difficile is another one of those common HAIs that we are all looking to eradicate and to not have happen in our hospital facilities or anywhere, because not only is it dangerous for the patients, but it really can lead to a lot of difficulties with eradicating it out of your system because it's such a sticky bacteria. It likes to really just hang around and be present. So we know that pure hypochlorous acid has the ability to disrupt these colonies after short exposure, and there's no clinically relevant resistance, unlike other solutions that we have available. Now, when you look at the effect of hypochlorous acid on adherent colonies with staph, you see you get a very quick reduction, logarithmic reduction within the first minute, but the sweet spot is around 5 minutes. So ideally, you're going to keep this on the wounds for about 5 minutes to really get those colonies as low as possible while you're treating these wounds. This has comparative cytotoxicity testing against other solutions. So this was shown that it's going to be safe around the mucous membranes, it's not irritating, and it's also safe for pericare. You compare it to chlorhexidine, povidone iodine, or hydrogen peroxide, none of those pass. They all are killing the vast majority of the fibroblasts and the keratinocytes, which are the fragile cells we need for healing. What's again the connection to pH and wound healing? As I mentioned, we want that sweet spot of the skin neutral pH, because the more we keep wounds in an alkaline environment, it's allowing the pathogens to thrive. It's causing much more inflammation and irritation, and it's keeping the pH as in chronic wounds. Now, I love my job. I've been doing my job for 23 years. I will do this forever, but I don't want to see the same patients for 23 years, because that just tells me that I'm not able to move the needle on some of these people. So I want to get these wounds in an acidic environment and more acidic environment and keep it there to make it more favorable towards healing. In our facility, all of the wounds are cleansed and covered with a compress while we're waiting for a provider evaluation. All of the wounds get a soak post-debridement and then prior to any cellular or tissue application. So, we use basically just one container of gauze, like you see there, and then 1 ounce of the pure hypochlorous acid. And with that, we're taking a piece of the gauze out and we're using that for doing our cleansing. Same thing for all of our inpatients. They're cleansed and they receive a compress. On the inpatient side, I'm going to be real, 5 minutes is sometimes not realistic. But as I mentioned earlier, if I can at least get it on for 15 to 30 seconds, that's better than nothing. Ideally, it's a minute. And then all patients that are getting dressing changes with negative pressure wound therapy are getting a compress and mechanical debridement prior to replacing the foam. So we may be using, again, one container of gauze or a Curlex roll, and then 1 to 2 ounces of pure hypochlorous acid. Now I'm going to go through a couple of cases. This was a patient who we treated who got admitted with COVID and developed a really scary, like a dangerous, like life-threatening condition called multi-inflammatory syndrome in children, who then developed an acute limb ischemia and had been cannulated for VV ECMO. Now, because he had gone back and forth, from different, the cath lab and the ICU and the OR, he was really, really critically ill. He unfortunately developed a deep tissue pressure injury, which turned into an unstageable buttock pressure injury. And then it became a stage 4 after bedside debridement, but didn't require further debridement from there. He was incontinent of stool despite the use of the fecal management system, and the patient's mother was at his bedside 24/7, and she was meticulous about making sure that we changed the dressings if she thought there was any incontinence at all. So typically, sometimes we would use a polyvinyl alcohol foam dressing, but typically the hypochlorous acid was used for every cleansing in the primary dressing for over 80% of his care. And this is how the wound first started out. You can see, it's tricky because it's in kind of the fleshy part of the buttocks where we don't have protective dressings because the protective dressings are higher up. And then it turned into this deeper wound here. We just were tracking it over time. You can see the fecal management system in place. We removed those in some instances to give a break, and then we put it back in. But you can see, fortunately, it was only into the deeper fleshy portions of the buttocks, and was able to get this wound completely moving in the right direction by the time the patient was discharged from our facility. And the wound went on to completely heal without having any additional surgical intervention for this patient. Now, if we talk about using Bosch as part of a treatment, this is a patient where, we have patients who will get their pre-tibial wounds, typically from something like a dishwasher door or a car door, but they get some sort of traumatic wound, and it really can take a very long time to heal because they're doing fine if they're not wounded, but then some sort of traumatic wound activates their underlying disease processes like venous insufficiency or arterial disease, which weren't causing an issue until the patient had a wound. So by using it as part of the treatment, we can get these wounds to improve slowly over time. This was a patient of mine who came in with a Marterol ulcer, that is a ischemic hypertensive leg ulcer. These are very distinct. They are typically in patients that have uncontrolled diabetes and uncontrolled hypertension. They occur over their Achilles tendon. They occur very rapidly, almost like a pyoderma gangrenosum type thing or a calciphylaxis, and they are intensely painful. This patient actually did not want to go to the operating room for treatment initially because she had another condition called Little syndrome, which has issues with potassium metabolism and contributed to her high A1C and her high hypertension. I'm not violating HIPAA here. This patient actually did live webinars with me on this wound because she was so concerned and wanted to get the information out about this wound. So what you do for these cases is you do a necrosectomy and you do a split thickness skin graft, and you can use negative pressure wound therapy or not. So she eventually got infected and had to go to the OR. And what you see there on the right is actually her Achilles tendon, which is part of that wound. So her pain improved dramatically after the escharotomy, and she was intolerant of any topical wound therapy that you can imagine. She couldn't tolerate hydrogel. She couldn't tolerate plain foam. But what she did tolerate was just having Vash compresses daily, and then the wound went on to heal with just Vash compress and a non-bordered foam, and then a cling to secure it. So fortunately went on to heal from there with very, very, high yield but low impact dressing that was easy to use for her. Now, when we talk about the cleansing techniques, some wounds that are hard to heal, they require a more vigorous technique to dislodge the loose devitalized tissue. And this is again on page 31 from there. So when we talk about recommendation 11, this is selecting a wound cleansing technique based on the presentation of the wound bed and the wound edges, the peri-wound itself, the surrounding skin, and then of course, what are the goals of care, what does the patient need, and then the local policies. So we can irrigate, we can flush, we can swab, we can wipe, we can scrub using a cleansing pad, we can do compresses, we can soak or bathe or do wet packing. There's a lot of people who still are using wet to dry. We do not want to do wet to dry. We want to do wet to moist or wet to wet to keep constantly lavaging and therapeutically cleansing these wounds. Installation with Dwell for negative pressure, and then again a hydro-responsive dressing is an option for us here. So how are you going to sequence this out? What we're going to talk about is communication. If I need to go up and I need to cleanse this wound vigorously, the patient needs to be aware. If it's on the inpatient side, the nurse also needs to be aware so they can be prepared and people know what's going to happen. This also involves, getting them pre-medicated. We're going to remove the old dressings and bandages, and then we're going to do therapeutic skin cleansing. This is different from wound cleansing. I'm going to talk about this in just a second, but you need to cleanse the skin as well as then going on to cleanse the wound itself. Then we're going to possibly debride the wound. Then you're going to do a post-debridement cleansing. I mentioned that our team does that after every debridement as well. And why is this important? You want to cleanse the wound post-debridement because all of the bacteria, which is actually causing the problem, which is down deep in the wound, has now surfaced its way up. And so you want to get rid of that as well. And then check the wound over again and complete your dressing procedure. So that is how you would cleanse with a different technique. So this is showing in my clinic itself. I mentioned this is skin cleansing for a patient of ours, and this is soap and water. So the wound is behind his thigh there, but you can see we're actually cleansing his entire skin because we use compression bandaging for this patient. So if we're not doing that, this skin is never seeing water. So then after we do the skin cleansing, which is up there, and now we're kind of close to the wound and we're getting rid of each new gauze as we kind of go, then we're going to move into the soak that we're doing here of the Curlex roll, like I mentioned, and we're going to let this compress sit. This is the wound cleansing that's happening now for this patient. So limb hygiene is critically important because we want to make sure that we're cleansing, drying the wound, and we're also applying a moisturizer. We have got to get some moisturizer back into these patients. Otherwise, you get cracks in the skin, which can lead to things like with lymphedema patients. We really want to maintain the right skin laxity and tensile strength there. And the drier it is, the more you can get a micro trauma, which can cause new wounds and cause bacteria to get in there. So with the peri wound, we want to think about recommendation 3 here, where we're therapeutically cleansing the wound bed, the wound edge, the peri wound skin, and the surrounding skin. So if you look at this image here, you can see where the bandage is for this, and all of that bacteria gets trapped under that as well. So you want to cleanse outside of the perimeter of the bandages itself. And now these are the therapeutic zones of cleansing. Now these are not exact. These are based on empirical observations, but you want to make sure that zone 1 you're getting, zone 2 you're going at least 4 centimeters greater, and zone 3 at least 20 centimeters from the wound edge. Now if you're thinking about a foot, what would you do for that? So with the foot, you always want to go one joint line proximal at least to where the actual wound is. So if the wound is on the toe, you're going down to at least the metatarsals or the Lisfranc, or going back to the show parts. If it's on the heel, you want to go all the way up to the knee. You really have to make it as proximal as possible, which is why using things like the Curlex rolls are very helpful. And why is that? You don't want to miss what you can't see. This is what I was talking about, those dry, cracked areas. And again, if you light it up with fluorescence here, you're seeing that bacteria is fluorescing red. So all of that bacteria is just sitting on that peri wound. So you can treat what you assume to be there, but what you really want to know is what's going on. So by carefully examining the peri wound skin and going outside of that, you're really helping to get rid of all of the, the wound debris, all of that flaking skin there. That's trapping bacteria in all of that. So you really want to address that. So this is showing an example of before therapeutic cleansing. And again, we're taking our bacterial fluorescence imaging. This is what's called the ring of fire. So when you see all of that bacteria there, that is, possible to march into that wound and keep it really, delayed healing from there. So after therapeutic cleansing, you're going to light it up again. And you can see, yes, there is still bacteria on the wound, but that's to be expected because there's slough and there's non-viable tissue. But you can see the peri wound has now been cleansed and has gotten rid of the non-viable bacteria that we don't want to have on there. So this is the summary of recommendations. This is can be found right on page 5, but and I didn't go through all of them in great detail, but it really, really helps for people to be able to lay this out. And these are things that you can, again, take pieces of this when you are going and you're thinking about how you're taking care of these patients. I want to point out number 5 is implementing universal protocols or universal precautions when you're conducting a wound dressing procedure, because what you don't want to do is be stuck when a patient has bleeding or any sort of issue post or more pain post. So this is why it's critically important to make sure, particularly in the inpatient environment, that you're involving the bedside teams, the nurses, whomever else, if you're the specialist coming in, that they understand that the patient was having a dressing procedure, and that you're also working with the patient to make sure that you're taking all of their considerations into effect. And like I said, the key thing is, unless it's an emergency, we should be pre-medicating our patients prior to doing any sort of dressing change, because it can can be incredibly painful. And if you've never had a dressing performed on yourself, don't underestimate how painful these can be for patients. So, we really need to take their consideration and their previous experiences where they may have had a very painful dressing change before, which caused challenges there. So, therapeutically cleansing the skin using a mild skin cleanser with a pH close to normal skin, doing your proper technique, cleansing the surrounding skin of the peri wound, and then therapeutic cleansing the wound bed is key to life here. I mentioned earlier, wounds are a buffet for bacteria. I just love this because this is what happens. These little gremlins just come up and, they are just having a party in these wounds. So I prefer to make them go away and to not give them a buffet and to give them a desert so that they can't survive on these wounds anymore. So what's the summary of therapeutic wound cleansing? Again, as I just said before, therapeutically cleansing at every dressing change. Every dressing change is an opportunity to change the trajectory of the wound and to ensure that everyone is empowered to deliver therapeutic wound cleansing. You want to select a solution that has an acidic skin neutral pH, but a high therapeutic index. Reminder, therapeutic index, you want that to be over 1 for these patients. And then picking the best technique to cleanse the wound based on what the wound is that you're cleansing, what the patient has going on, and then what's the actual setting. Hospital beds are really, really gross and dirty. If you think about how we cleanse wounds when we're in the operating room, we are getting them as sterile as possible. And people have, sterile gloves. The providers, the surgeons, the scrub techs, the nurses, they have all scrubbed their hands for 2 minutes prior to putting on these sterile dressings, sterile gloves and gowns. I'm sorry, and then they're working to get these wounds as clean as possible. So 2 days later, if we go back to the hospital bed and we're not doing any sort of cleansing of the peri wound or the wound itself, it's no wonder that bacteria is already coming right back, because we know that with biofilm reformation, that the bacteria is stuck on some of these wounds and comes back very, very quickly. So therapeutic techniques should be used in all aspects and all settings to help clean these wounds. How do you justify this from an economic standpoint? Well, these papers have been published. You can actually scan the QR code there to download a white paper on the economic and quality impacts of this. So if you are comparing using Vosh to a Dakin solution or saline, they found that there's a 7-day healing reduction time, which is saving approximately $142,000 per patient in the operating rooms when using it as an irrigation over pressure injuries, versus saline, you're saving $3,000 to $33,000, and you had 55% fewer complications. Again, in the critical care setting, used as an amplifier or in conjunction with debridement compared to saline, you're saving $440 a wound, and the home care environment over $836,000 annually. And this is if you're looking at doing it as a wound soak for diabetic venous or pressure ulcers against various cleansers. And again, in clinic, you get this various cleansers, you get a huge reduction as well for those. So not only is this appropriate, it is economically appropriate. And this is what's important when you're talking to your C-suite, that we want to do the right things for the patients, but if we can also do it in an economical manner, that is always a boon and a pro for everybody. So with that, I want to again give you an opportunity to scan here to download your own copy of the 2025 guidelines. Additionally, if you go to the IWII website, you can get a copy of the 2022 paper on best practices for treating wound infection. This goes hand in hand. And honestly, this guidelines document came out as a result of that paper, so that people had an opportunity to really dig more into the critical importance of therapeutic skin and wound cleansing. So with that, I thank you for your time, and we're gonna open up to questions. So I hope that this has been informative and appreciate your time today. Thank you.
Thank you, Kara. Now, we've been watching the chat and have some great questions coming in from all across our social media platforms. And we'll get to as many as we can as time allows. So Kara, are you ready to dive in here?
Let's do it.
Right, we have a question here about our old friend saline. You had mentioned that saline doesn't have a measurable therapeutic index. For facilities with limited budgets, what's your recommendation for transitioning away from saline as the primary cleansing solution?
So I think what you need to do is compare it to other cleansing solutions that you have. And this is going back to what I said on like the very first slide, as far as many facilities have multiple options for cleansers. And I actually did the math where I went and I looked and I said, how much does it cost me to use an ounce of saline? How much does it cost me to use an ounce of povidone iodine? How much does it cost me to use an ounce of Vash? How much does it cost me to use an ounce of chlorhexidine? And I was actually shocked that for me, it cost me 80 cents to do an ounce of povidone iodine versus I think it's 42 or 43 cents for an ounce of hypochlorous acid. So nobody thinks anything of taking bottles of povidone iodine and just liberally dousing them all over the place. But if you look at what you actually spend, you are spending more money for these other cleansers. So I think that if you look at it from that standpoint, that really helps because people get caught up in like the bigger numbers. But if you think about my patient that I showed, that the young man that had the pressure injury on his buttocks, that patient was in the ICU, had been in the operating room, had at least a six-figure bill. I have no idea what his bill was, but I can assure you it was at least six figures, if not seven figures, and it probably was in the seven figures. But I estimated that I spent about $500 in a wound cleanser for that patient for that wound, and again, avoided him going to the operating room and things like that. So that was a very economical choice for that patient. If you don't have, any option, and saline is your only option, of course, use saline, but understand that you are not getting a reduction in bacteria, in cytotoxic, and in the bad cells, the end products, because again, it doesn't have a measurable therapeutic index.
Thank you, Kara. Now, we're talking about a shift at the bedside here. So, how do you educate non-wound care nurses and staff to perform therapeutic cleansing correctly? What are your main teaching points when you're working with staff on cleansing protocol?
Well, I think that's it's the old, phrase like see one, do one, teach one. So, inviting the bedside providers, whether it's a patient care tech, whether it is the primary team, whether it is the bedside nurse or any other, specialty that's associated with that patient, have them come with you to the bedside to see what you're actually doing, demonstrate it, have it in writing, watch them do it. And then they feel that they have confidence and they know what to do and they know how to do it without hurting the patient. Again, if you're doing some sort of vigorous scrub or things like that, like we obviously don't want to be torturing our patients. So in some instances, a compress is going to be more appropriate, but just as effective, where I'm not doing a vigorous scrubbing of the wounds themselves. And so some frontline staff may feel more comfortable with that, but just having them understand also the critical importance, like I mentioned, of doing the zones of cleansing and really getting outside of just what the wound itself is, particularly in hospital beds that the patients have been rolling around in that may have drainage. Even if you put a truck or something under there, I mean, we all know that we have bacteria on our bodies. If you think about the bacteria that's in these wounds and in the peri wounds, as we showed, it is usually much more virulent. And also these patients already have open wounds. So they're already, if they're in the hospital and they have a wound, things are not going well for them at that moment. If they're at home and they have a wound, things are not going well. So we have to do what we can to optimize that environment as much as possible and really trying to get things clean, because most dressing changes are not sterile unless you're in the operating room, and that's okay. But that's even more reason why you do the skin cleansing and then you do the wound cleansing with these patients.
Yeah, that just makes so much sense. Now, next question here is about documentation. How do you document therapeutic cleansing to justify the time and resources to administration, especially when trying to implement new protocols? So going back to C-suite and saying, hey, this is what we need to be doing now.
So I think you can think about your workflow. If you're talking about like the inpatient environment, I'll talk about inpatient first, then I'll talk about the clinic environment. And then the home care setting is kind of similar to the clinic environment as far as the timing. So on the inpatient side, what you can do is if you already have your, bottle of your hypochlorous acid at the bedside that you're going to do, you take the old dressings off, you do your cleansing, you let that sit, and then you go get the new dressings that you're trying to use for the patient. So by the time you come back, you've had the 3 to 5 minutes. By the time you get to the supply closet and you come back, you've had time for that soak and that solution to really be on the wound, that antiseptic, to allow for the next phase where you can simply just remove it at that point and put your new dressing on, and then you're good to go. Now, if you're talking about the clinic setting, same sort of thing. And we do it, I think, the same way that a lot of people do it, where one of our medical assistants or our nurses will bring the patient into the room. They'll take all the old dressings down. They will do therapeutic skin cleansing, and then they will do therapeutic wound cleansing, and then they will take pictures and images and do all that stuff. And then they're, they let the provider know. So by the time, again, the provider gets in the room, like the first steps happen, and then they go to the next patient, and then they go to the next patient, and then if the provider does a debridement, they simply apply the post debridement soak, or any sort of mechanical debridement they want to do right when they're finished doing the debridement themselves, and then the MA or the RN or whomever comes back in to do the dressing, the closing dressing at that point. So I think it works very similarly. I've worked in a lot of different wound care settings. I don't think that, I think there's more than one way to do it, but that's a general commonly accepted way to do it, where you're not wasting time. And you just need a few minutes to get this done appropriately for the patients to really get the maximum bang for your buck here.
Great. Thank you, Kara. Now, have you used this in the peri-op area for decolonization when you have patients with allergies to other solutions? And I'm assuming we're talking about pure hypochlorous acid. And maybe we speak to this therapeutic skin and wound cleansing technique as well.
Yeah, so we don't use it as a common time, but we certainly have patients who have an allergy to chlorhexidine or things like that. And I have spoken to different teams with that. And we will do a soak before we do that to try and prep skin, things like that. We often use pure hypochlorous acid in the operating room as an irrigation as well, and we also use it when we're doing negative pressure wound therapy with installation and dwell as a lavage as well in that instance. So, yes, you can use it. Again, I mentioned earlier, it's safe for mucous membranes, it's safe for pericare, it's safe for C. diff, things like that. But so, yes, if you needed an alternative to, povidone iodine, if you needed an alternative to chlorhexidine, I think those are kind of the most common ones. You can safely substitute or choose hypochlorous acid, pure hypochlorous acid in this instance.
Great. Well, thanks for addressing that, Kara. If you haven't submitted your questions yet, please do so in the chat, real easy. We'd love to hear from you. And while we're waiting to hear back from some other folks here in the audience, we want to talk about one of your cases. So you showed examples how long where we saw some great improvement from the therapeutic skin cleansing process. We have somebody here concerned about the time it might take based on their patient load. So can we I know you talked about that a little bit, and might take a few minutes, but can we talk a little bit about time? How do we address that time, that concern of time and time constraints versus the number of patients that we need to see?
Well, again, obviously, we all have workloads. We all have things that we need to do. And I think that if you have a routine and a way that you're used to doing it, again, like 5 minutes is the ideal sweet spot, but you're getting a kill rate very quickly. So I think even if you're spending 30 seconds to a minute, allowing things to be on, and you can be doing, allowing a soak to be on, I'm sorry, but you can be doing other things like prepping your dressing to, once you take your soak down, you can be doing things as you're going. If you're in the inpatient room, you can be cleaning up the room. I mean, sometimes there's like debris and detritus around, like we call it, like wound bed trash, that there's like things that are left in there. So sometimes that's what I'm doing while I'm waiting. But, the key thing is to get it on, to use the hypochlorous acid there and get it in contact with the wound and in contact with the skin. And if you only have 30 seconds, you only have 30 seconds. There's what is it? The opposite of perfect is good. So you want to. I totally mangled that. That's not the right phrasing,
We know what you
but
mean.
you know what I mean. But you know what I mean. So it's don't get held up on that. It must be 5 minutes. 5 minutes is ideal. If you have the time to do that, yes, please do so. If you don't have the time to do it, take care of the patient and move on. We all have days where your censuses are exploding and you're trying to get stuff done as much as possible. But if you have the opportunity to have it standardized in your practice like it is in ours, it makes it easier because everybody knows what they're grabbing for. Everybody knows what the cleanser is that they're using, and no one is surprised to see that in the rooms. So we do our best to make sure that that they're doing it as long as they possibly can. But obviously, I realize that people have competing priorities for their time.
Right. And then with using a product like pure hypochlorous acid, we're you'd mentioned that kill time is so fast.
Yeah.
You can really have a lot of impact in a short amount of time.
Yeah,
We
absolutely.
have time for one more question, Kara. Now, you showed some impressive results with hypochlorous acid. Are there any wound types or patient populations where you would not recommend using pure hypochlorous acid?
I mean, no, we use it pretty much everywhere. Like we use it in our NICU. I will say in the NICU environment, because especially depending on how tiny those little sweet peas are, it like a 24 weeker, 25 weeker, you have to think about the temperature, meaning you don't want to put a cold solution on a fragile little baby. So in that instance, we may put it in a container and then have it in like the blanket warmer, or like in a warmer inside the isolette first before we apply it to the baby. But those are just some kind of things that you can think about. But again, our body makes hypochlorous acid naturally. So that's why we don't have resistance to it. So you can apply it on mucous membranes. You can apply it in the peri area. I have used it in, fungating tumors like all the time. I've used it over acute radiation injury. So it's used intra-abdominally. You can, really apply it anywhere. And I think that's one of the reasons why that's part of we have a standard order set that's what we call our wound care starter order, because we know that patients get admitted to facilities after hours or on the weekends when the wound team is not there, but the teams can have, comfort knowing, because again, wound care is not taught, that they are choosing something that's not going to harm the patient. If the wound is doing okay and it's healing, that's great. If it's not doing okay and it needs more love, that's also going to do that too. So they can have comfort in knowing that they're applying something appropriate while they're waiting for expert consultation.
Tara, thank you so much. This wraps up our inaugural Learning Live session sponsored by Ergo Medical. And if you want to dive deeper into today's topic, I encourage you to visit Wound Care Today USA at wct-us.com. Check out the Wound Cleansing Microlearn category for additional evidence-based education, and don't miss the interactive product and practice on Vosh. It's very cool. And it's a fantastic resource that complements what we just discussed today and learned about this technology. A very sincere thank you to you, Kara Couch, for sharing your expertise and joining us for this first ever Learning Live broadcast. And thank you all for being a part of this new format with us. Your engagement in the chat has been wonderful. I would also like to extend a warm thank you to the Ergo Medical team, who's been here behind the scenes here, supporting us for today's session and making this new educational initiative possible. Before you all go today, if you found this valuable, please like the video, share it with your colleagues, and follow us on your platforms of choice so that you don't miss future Learning Live sessions. We have another one coming up in November with Dr. Rob Klein. We're going to be talking about diabetic foot ulcers, so be sure to sign up and get some updates from us. This concludes our implementing the 2025 IWII guidelines, making therapeutic wound cleansing standard at the bedside. On behalf of Wound Care Today USA and Ergo Medical and our guest today, Kara Couch, we appreciate your participation. Be well and enjoy the rest of your day.
Thank you.